Morning, everybody. My name's Johnny. For those of you guys who've not met me, PYG-2. I'm going to give my small talk today about the evidence behind our use of cervical collars. Just special thanks to the small talk team. So, just going straight into it, why do we even use cervical collars? I think that's a question we all think of all the time. But I think it's always that the feared complication of having that unstable C-spine injury that we missed, right? The one that is coming, walking, talking, everything's fine, and then because they moved or somebody sneezed and suddenly had this jerking motion, and they're suddenly paralyzed and they lost all function, right? To go from that severe of a drop of disability, especially like the medical legal consequences of that, is very high, and that's probably what's driving a lot of this use of the C collars. I mean, there's no really great cases, but like we keep getting like case studies like this where you had this like 80-year-old male who fell. Initially had like some imaging, was fine, walking, talking, and then later on they did some spinal clearance, which for the life of me I could not figure out what they were using to clear him, because all they got was the X-ray. And then later on they noticed that he became quadriplegic and later died. And they repeated X-ray and you see this massive dislocation of the neck. So, yeah, I don't know what they're doing, but we'll see what they're concerned about. So, what are these unstable C-spine injuries? All right, there's a great mnemonic for it. All right, I'm pretty sure you all heard of it. Jefferson bit off a hangman's thumb. All right, you have like these 6 supposedly unstable C-spine fractures. And we're just going to go rapid fire through a couple of these images, and you guys can just shout out which one of these you guys got, okay? All right, what do we see? I heard hangman? No. We have a complete, like, all right. Let's go back. So let's review the names of them first. All right, so we have a Jefferson fracture. All right, this is like a burst fracture. B, bilateral facet dislocation. Off for odontoid fracture. A, atlanto-occipital dislocations. Hangman's fracture. And teardrop fractures. All right, so you got 1 of 16. Bilateral facet dislocation. You can see this complete translocation is like a complete ligamentous disruption. All right, very unstable.
You go back to those. Also, the rule usually is if you have a vertebrae moving 25% over, that's at least a single facet dislocation. 50% over, it's a double, and that's very, very unstable. And that's like 50% over without anything else.
The other thing too, remember that the facets are on the lateral part of the spine, and you're only seeing a middle cut here. You can't tell if it's dislocated or if it's off. Normally, you should have the facets aligning front to back, front to back, front to back. And with the dislocation, one will be flipped or a hole will be flipped.
Yeah.
You really can't see the facets in this image, but you just have to assume it due to the extent off.
Yeah, like on these lateral sagittal images, you should really look for like the 3 lines to see like if these line up well, which this is clearly off. All right, next one. Odontoid fractures. All right, so depending on the level of it, you have type 1, type 2, type 3. 1 not being like pretty stable, 2 relatively, and then 3 like anywhere below is pretty unstable. All right, next. Teardrop fractures. not a fracture of its own. Yeah. So it depends on like which way you see it kind of going. All right. Next. Jefferson. So it's a burst fracture, right? Do you see you have the atlas fracture? Usually like at least 2 spots, but like also 3, 4 different fractures on it. And then next. Hangman. Yeah, this is Hangman's fracture. This is like the traumatic spondylosis of the axis. We have fractures of the bilateral pars. And then
You're only allowed 11 millimeters between the tip of the dent and the basion, which is the frontal frame of the neck.
yeah. So what Dr. Silverberg is referring to is this spacing here. This is all atlanto-occipital dislocations. It's not so much a bony injury, so you're not really going to see any bony things, but you just look for the spacing. There's like a lot of measurements that we probably won't know, but the radiologist should see like the distance of this off. All right. So, you know, we have all these scary fractures, right? So what evidence do we have for, you know, using all of these C-spine collars? I'll say not very much. So there's a lot of studies that kind of like touch on vaguely retrospectively like that C collars are useful, but we have a lot more that kind of goes against it. So this first study that I saw was like this compression injuries on the cervical spine. Essentially, this study kind of proved that it's not so much movement that causes these unstable fractures, but more so the energy. So they did a study with like human cadavers where they actually put pressure on the head to see like how much force it will take to actually until it fails, where they have like that give in the pressure, and that's where they had like the create an unstable fracture. So this study kind of first off kind of proves that it's more so the energy of the impact and usually the trauma that causes it, and not so much the movement. So, you know, how useful are these collars? And it's because it doesn't prevent any energy, but kind of limits the movement. But then we got to ask, like, does it really limit any movement, right? So we have more studies that kind of show that it really doesn't limit that much movement either. So this was another study where they had like a bunch of paramedics and first responders kind of simulate extraction. You know, first one using just like verbal commands, having them self-extricate versus you know, the conventional way that we do it nowadays with like the collar, having them move on the, well, not so much the longboard anymore, but they essentially show that there was actually much more movement when they tried to use the cervical collar during extraction rather than just verbally having the patient just follow commands and having them self-extricate. So essentially, now we got two things. Collar doesn't really prevent the energy of it, and it really doesn't really limit the movements of it either. So what evidence do we have? But you know, that's also kind of circumstantial. They kind of did it on cadavers, they did it in simulations. This isn't really like a prospective study. But you know, what's the harm in doing it, right? You know, in theory, it should still technically work, right? We have even further studies that kind of show that it actually can cause some harm. You know, this study here, the motion within the unstable cervical spine during patient maneuvering. Essentially, what they found in this study, what they did was in this one, they actually broke the neck of 7 fresh cadavers, placed C collars on them, and then would rock them like similar to how we would rock, you know, either to roll them over to check the spine or just during patient transport. And essentially, they saw more movements of the C spine when we use these collars. You know, they did CT before, CT after these movements, and they saw much more significant movement afterwards. And the theory behind this is that, you know, because of where the collar is, right, you got these pivotal points which are now on the side on the collar. So it actually deviated the axis of the force to more off from the midline to more on the lateral. And so that actually created more lateral movements of the C-spine. At least that was their proposed idea of like why there's so much more movement. All right. So now we have evidence of harm as well, but we go into further studies and we say, well, okay, maybe it's not just C-spine stuff. There's other harm that it can be causing as well. This is another study that now shows that there's an increase in CSF pressure in patients who are placed in C-collars. So they took 20 patients who were due for like a spinal tap for other reasons, did the spinal tap, measured the pressure, and then they would place them in a C-collar afterwards, and then they would measure the pressure again. And they noted that on average there was like at least a 20 centimeters of water pressure increase after placing the C-collar. All right, I know. So, again, this is not directly looking at trauma patients and seeing this, and this 20 centimeters of water increase in pressure, the clinical significance is unclear, but we do see this increase in intracerebral pressure because of cervical collars. So great. All of this has been theoretical still, just because it's really hard to do any prospective study on trauma patients regarding this. But what happens if we were to compare the practice between two different countries, like us here in New Mexico versus in Malaysia, where they have no spinal immobilization during this? And essentially, when they compared these two hospitals, similar patient population, similar resources available, us with the tendency to always use spinal convulsions, and Malaysia, who they don't do any of this, they actually found that there was actually more severe neurological disability in our patients compared to Malaysia, where they do not do any sort of spinal convulsions. And they defined severe disability as complete quadriplegia, paraplegia, inability to ambulate without assistance, incontinence, or like frequent catheterizations. So now there's now some evidence that it's actually showing harm in patients when we immobilize. Granted, this paper combined not just cervical traumas, but also thoracic and lumbar traumas as well. So despite all that evidence, somehow our current recommendations is a consensus through all of these major groups that spinal immobilization is recommended in all trauma patients. So what are they basing all this off of? To be fair, it was really hard to find what they were basing it off of. What I did find was one review article. Essentially, they just searched for all the papers with any mention of spinal immobilization and trauma. And what they found was that they estimated that 3 to 25% of spinal cord injuries actually occur after the initial trauma incident. But their conclusion that they came to was that this is just a time-related practice based on anatomic and mechanical considerations in an attempt to prevent spinal cord injury suspected by years of cumulative trauma and triage clinical experience. So essentially, there's just because this is what we've done and what we've seen for so long, this is what we will do and continue to do. But what do we have to help us in these cases? We have the Canadian C-spine rule and the nexus criteria for helping us. Essentially, we've all used this multiple times, probably daily. But the Canadian C-spine rule, they did a validation study with nearly 9,000 patients from 16 to 64. And essentially, they had like 100% sensitivity for ruling out cervical spinal injuries. The Nexus has similar sensitivity with like a 99.6, but like validation studies have seen is like more like 83 to like 100. But again, these are really great for ruling out C-spine injuries. Doesn't mean that if you can't apply them that they will have one, but they're really good for ruling out. All right. So just kind of close up a little bit. So just some take-home points. The severe complications of C-spine injuries. You can remember them based on the mnemonic Jefferson bit off a hangman's thumb. There really is no good evidence that cervical collars prevent harm, and there is a growing evidence that it may actually cause harm. And lastly, use the nexus and Canadian C-spines rule, and they're really good for protecting us a little bit legally when we do rule out C-spines. There's a reference question.
I think